this one also. These are quite the cases that you want to do. Provided all other factors means not too fat, medically fit, not so anxious. I think these are the good cases. This one very short route, so okay. Quite relatively, I think, doable in your capability, right? Similarly, if I see this, sometimes I will tell them, you're not sure whether it's hooked, right? So I just make an outline. I do not force my patient to take CBCT. Okay, even if you have CBCT in your setting, sometimes you might want to say, hey, take a CBCT, I cannot see, isn't it? Now, sometimes patient has financial constraint, not that they don't want to, okay? So what do? I will tell them, of course, yes, I recommend one, but in my place, I have CBCT. And if you do not want to, I will assume everything is at a normal position, I will still proceed. However, whenever I think I'm having difficulty during the surgery, I may want to stop and ask you to take a CBCT immediately. That's what I would tell my patient, because I have CBCT. So after that, they take a CBCT, biting gauze like that, take a CBCT, come back and interpret, and I will do what I have to do following that. The new information that I get. Understand? That's for me. So I don't insist, you don't take CBCT, I'm not going to take this tip unless memang very distinct features lah, like maybe cyst, maybe pathology, things like that. I will keep my firm stand and say I will not do it unless you have a CBCT. But if a case like that, I don't insist. I just tell them the risk. I recommend, but patient refuse, write down lah. Recommended CBCT, patient do not want. And then tell them that you might want to do this. And in your case, if you don't have a CBCT with you, you have to tell them, I may choose to abandon. Because we don't have this, because you do not want to have a CBCT yet. Understand? And at any times, you can always say that specialist input or referral can be considered. The moment you say this word, you are safe, because you offered. Then the patient, next question, how much? Next question, they'll ask you, how much specialist will charge me? Then you tell them, my price is 800 to 1,000. Specialist price is 1,002 to 1,005. Then the patient will think, okay, I do with you. Understand? At least you offer, then they don't want to, it's okay, you write down. And whenever things go wrong, I did offer you. But you didn't want to. So, alright, Right, so red flags, elderly comorbids come with both parents and ask a lot of questions. Not the patient, but the parents. Chubby, smoker, limited mouth opening, TMJ dislocation, sensitive gag, very expensive crown or implant next to it, fully buried. Usually fully buried are not symptomatic, so we don't really have to take out fully buried teeth. Unfavorable root anatomy, occlusal table 8 lower than 7, very tightly wedged with the 7, or the 5 features. Narrowing of the interruption of the white line, deflection of the roots, darkening of the roots, and narrowing of the canal. Right? You can memorize already. Very good. Now consent. Okay. Right. Consent is about telling all information. In fact, I covered a little bit already just now, because when you see a case, you would know what you want to highlight. So it's very important to tell them what could happen before it happened. But of course, you don't want to scare the patient. I understand, I read through your forms, so I will demonstrate how I take consent in a way that it doesn't scare the patient. Alright? If you tell them first and it didn't happen, they will be happy. But if you tell them first and then it happened, they usually won't blame you because you told them already. Okay, so I always reinforce their motivation, means that, gigi bongsu ni memang kena cabut sebab dah berlubang. I always say it again because I'm telling them this is the indication. I'm not asking you to remove it. You come and you need my service, so now I'm removing it. It's important because they know it's not like, I pun tak tahu kenapa nak cabut gigi bongsu tu, doktor kata kena cabut, I cabut lah. Then they'll put all the blame on you. Then it's not the way it should be. Right? So you fulfill the indication, I'll tell them, you fulfill already my tick checklist. Memang kamu memenuhi syarat untuk membuang gigi bongsu ni, so then I take it out. Right? So you fall back to CPG. That's why you fall back to CPG, you're never wrong. Okay? Right, so all these you can mention. I won't go through bit by bit. This one I mentioned already. This one. Always ask you one. So is it permanent, doctor? I forever feel numb. Always they'll ask you this question. So how do you answer and how do you handle and discuss nerve injury? So we have two nerves that we will encounter. This is for academic purpose for us because we understand there are two nerves. Lingual is when your retraction, infraorbital nerve is the one in the mandible. But I never tell them that there's two nerves involved. It's just too complicated, it makes my consent too long. I lump them together. Even this table, I lump them together. Lowest number is 0.28, highest number is 0.9. I don't even tell them there's a temporary and a permanent thing. I always just give one number because it makes them easier to understand. So you routinely, I will just say 0.4 to 0.6. Okay, 0.4 to 0.6, and I'll just tell them it means 1,000, 4 may have injury, between 4 to 6 in 1,000 patient, right? So how do I explain? Okay, so this one I think I can skip, don't worry, I already mentioned it. So I just go straight into a case. Miss Low, 24 years old. So she came, I do my examination, she's a 4th year law student, no medical illness, BMI 19 is good, 19, quite skinny. TMJ, no clicking, mouth opening is good. Lymph nodes are palpable, not tender. She wants to take out her right lower wisdom teeth because of toothache, which is 3 times already. 1 time also is, for me, not considered recurrent. More than 1 time only is recurrent pericoronitis. So 3 times, tick. My box, tick, can take it out, alright? Right, so this is her OPG. So what is important? So she'll go and take OPG, will come back, okay, Miss Low, this is your OPG, and I always will do this. The letter L means left side, so all this is the left side, all this is the right side. Those are your upper teeth, these are your lower teeth. Your area of concern today is here. So this is your wisdom teeth, and this is the teeth in front of your wisdom teeth. Well, here I can see that the wisdom teeth is lying horizontally, so there's no way we can take it out. And because of your recurrent pain, I think you're having caries, the teeth in front, and the wisdom teeth itself. For any doctor to do a good feeling for you, most likely you need these teeth to be removed. Once it is removed, food will not get stuck, your filling can be successful. The treatment for the teeth in front can be successful. Usually what we do is I give a jab, I make a small cut over the gum, I flip it to the side, and I will remove a little bit bone around it to give space. After that, I will separate the teeth and they will come out part by part. What's interesting for your case is that the root is slightly curved. So the teeth actually wanted to come out in this direction, which I will break it into pieces and hopefully I can take it out in a different direction. What is want to bring your attention is you can see this white line here, you have one here and you have one there. So this is actually the nerve. So your nerve and your teeth are quite close in the X-ray, but because this is a two-dimensional view, I don't know how close are they. I will put my hand in front of the screen every time. I do not know if they are this close or this close. And the patient will understand immediately. So what happens if they are too close and I take it out? Sometimes the nerve can get abraded, terjalak, and you might feel slightly numb. Certain areas, including your chin, your lip, and half of the tongue. So what does that mean? It means that if you drink a hot cup of coffee and it touches your lip, your right lip cannot tell you that the cup is hot, but the left lip can. Giving you another example, if you're eating and one rice is dropped or stuck on your lower lip or your lower chin, you may not be able to feel the weight or the wetness of that grain of rice. Then someone will teguk lah, sedap sangat sampai kat luar ada, and you embarrassingly wipe it away. In terms of your tongue, maybe food doesn't taste as tasty because I cannot perceive the taste of your food as well, that well. So kedai yang sama, menu yang sama, tapi tak sedap. But it doesn't affect the way you smile, the way you speak. Only you know that you are partly numb over this region. Tetap seumur hidup doktor, forever. Well, most of the nerve injury will recover around 4 to 6 months time. I will see you and I will give you some medication to help regeneration of the nerve. But if I continue to see you up to a year, and then most patients will tell me at first, kawasan terlibat tu banyak, but it reduced with time to an area maybe 20 cent, 50 cent, and you have already been on the medication, and with my follow-up up to a year, that remaining part most likely will be permanent. So I won't tell them yes, it will be forever, or no, it will be forever. I will tell them that your nerve regeneration process is long. It's not a matter of days, it's not a matter of weeks, it's a matter of months. So they have realistic expectation. They don't keep message your clinic, they don't keep calling you, because you get stressed out, Then you do one MOS, you don't want to do any more MOS really. So you see them, you give them medication, but you see them timely and tell them to be patient. And if they do reduce to that little bit area, usually they're used to it because they don't affect most of the function. And I don't separate the nerve. I don't say inside ada satu saraf lagi tau, yang tu in charge untuk lidah. Because I lump them together because this is the nerve that they can see. So they will assume this nerve is responsible for all that. That's it. And that is all that matters for them, and it saves my time. Understand? So lump them together. Okay? And then of course in this case I'll tell them, so once I do this, I will definitely check again. I put in my mirror and tell you whether there's a cavity or not. Because sometimes you think there's a caries, but there's no caries, it's just decalcification or white spot lesion. So although as frank as I really think it's a cavity, I will still tell them, I will definitely tell you during the surgery, memang berlubang kena tampal atau tidak. Because it's not easy to do filling here. Anyone have done that? Harder than MOS, I think. DME some more. So then they will also ask, when can I do the filling? Because sometimes they come and see me because they want the filling on 7. They don't want the 8 removed, but the dentist recommend them to have the 8 removed. So my concern is not your 8. My concern is how fast can I have a filling done for my 7? I will tell them I routinely advise a month, but that's quite long actually. Earliest will be 2 weeks. Can you do it together simultaneously? I say no. Reason is because the turbine, the compressed air of the turbine will have air. I raise a flap. I use a high-speed burr there. I will cause emphysema. Air will escape to your facial planes. You get this surgical emphysema. You really don't want to handle surgical emphysema. The most you want is manual instrument and some Calzino, if the most you want. Even that I don't do because the Calzino dropped into my socket. Okay, so usually I don't do anything for the 7. I leave it as is. Maybe I just clean the posterior side, but I don't do anything for the 7. Once it healed, the gum has healed fairly nice, and all the edema has settled down. I would say maximum, fastest 2 weeks, you can see a dentist and do the filling. Right? I don't do together. That's how I will explain to them why also. Nanti ngilu tau. Isi tu pun masih belum matang. Nak straight nak buat filling already, and the pressure from the handpiece lah. Alright? And also, in this case, I will tell them, you also have upper wisdom teeth, okay? And then they are slightly down, over erupted lah. I would say this is a line, this is the level where it should be. This one has dropped down a little bit because they don't have opposing teeth.